was surreptitiously put here so you could forget all those pictures of stool before lunch. Everybody's going to have to try to zen that out or something. Quickly want to go through a little pancreas cancer as we deal with it in the multidisciplinary clinic. And so the first thing that we have to make certain that we're talking about, let's see if I've got this correct here, is that we're looking at pancreatic ductal adenocarcinoma for the most part. Although our clinic will see everything, including acinar cancers, which actually make all those little enzymes and put them through the duct, or neuroendocrine tumors from the islets. We're going to focus primarily for the moment, but a lot of what I say will also have to deal with the other types of tumors. And I'm going to give you a few slides as to why this is such a booger of a disease. And that is because by the time we actually see it, for the most part, it is spread. And what do I mean by that? This was a wonderful study done by Christine Donner-Bruzio when she was at Hopkins, and it was done as a rapid autopsy series. They had about 60 patients who donated their bodies. They would biopsy the normal tissue, they would biopsy the tumor, the metastasis, and they would use standard DNA techniques to take a look and see when did the tumor start and when did it learn to metastasize. Well, the initiating tumor event happened somewhere between about 8 and 15 or 20 years ago. And the parental clone became metastatic somewhere on the order of between 2 and 5 years ago. So by the time they actually present to us, they've already got micrometastatic disease. And this goes along with the issue of resecting these, removing these tumors, and then giving them post-operative or adjuvant therapy. And we'll talk a little bit about why that paradigm is probably not good. And in order to change that paradigm, we've adopted this multidisciplinary clinic treatment system. So what makes it difficult? There's very few early symptoms. Early invasion metastasis, they tend to be chemo-resistant for a variety of reasons that we'll talk about, and they have debilitating cytokine-mediated symptoms. These are people who have bad diarrhea, as Dr. Gelrud talked about. They'll have wasting, they'll have anorexia, they're going to have early satiety, they're going to have fevers and chills and night sweats. And it takes forever still to diagnose many of these folks, at least forever in a medical time frame. And so what about screening? Well, unfortunately, there's no pancreaticogram like there's a mammogram. There's no pancreatoscopy like there's a colonoscopy. There's no cross-sectional imaging that actually will help find these earlier. And CA19-9 is not a sufficient predictive value. EOS and CT is impractical and also, unfortunately, not predictive and unreliable for that. So just to give you an idea of why these things have so much trouble, why do we have so much trouble with these pancreatic cancers? Well, there's the microenvironment itself, which is somewhat hindering chemotherapy and the immune system from getting in there. So there's this large fibrotic mess surrounding the tumor that inhibits drug delivery. There's low blood vessel density. There's the cancer actually causes more connective tissue to be deposited around the tumor, in a sense protecting itself. Inflammatory signaling also causes an anti-tumor environment. On the metabolic side, it turns that the tumors are very good at taking up glucose, very take up glutamine. They can feed themselves by macropinocytosis. So they actually grab the albumin that's sitting in the blood and they use it to feed themselves and break it down, which is not a normal mechanism. So for all these reasons, it can be difficult. And here's your classic presentation. It's somebody in their mid-50s to mid-80s. They've got unintentional weight loss, loss of appetite, early satiety, fatigue. Some of them have new onset diabetes, some have worsening diabetes, abdominal pain, back pain, but everybody has abdominal and back pain for the most part when you get to this age. And not rarely, but obstruction and jaundice will bring them to you quickly. But for the most part, that's not what you see. So the classic evaluation, if they're jaundiced, okay, you show up in an emergency room, you see your PCP, they'll get a CT, they'll get an EUS, you'll find it pretty quickly or so. And then you can intervene with an ERCP to put a stent internally, or you have interventional rheology, go from the outside, or as Dr. Gelrud used to do when he was here, have them meet at the same time. We used to love to try to do those. But usually what happens is it takes many weeks or months, and they'll see their PCP, they'll go to the emergency room, they'll go back to their PCP, they'll have multiple blood tests, all of them are off a little bit, no one really knows what to make of it. Eventually the pain gets so bad they get some sort of cross-sectional imaging, biopsy, and a CA19-9. And you gotta be careful again about the CA19-9. Remember, if you've got a mass and it looks like adenocarcinoma and it's elevated, it helps you decide that it's gonna be a cancer. But it doesn't have to be elevated. It can be completely normal. 10% of Caucasians and up to a third of African Americans don't have an elevated CA19-9 because of the way that it's measured. So, what happens with this MDC components? Why are we talking about? And we actually will meet, as a matter of fact, right after this. I have to go to Presby for our afternoon pancreatic MDC. And there we have folks from the GI helping us doing screening, EUS, ERCP. We'll ask them if they're jaundiced to try to help us relieve that, for instance. Some people have tumors so big that they actually block the duodenum, the gastric outlet obstruction, and they have to put stents in for us inside the duodenum, a larger stent. Radiology is there to help us decide, is this removable, is it not removable, surgery, and what the blood vessel is going to be there for screening. IR sometimes has to help us put in stents as well, as we talked about. Pathology is really important. They're not physically there, but we call them up all the time, and we ask them, do we really have a classic adenocarcinoma? Is there a possibility it's one of these other neuroendocrines, acinars, et cetera? And we're doing more and more genomic sequencing. I won't really get into it, but we turn to the pathologist and say, does this have an Achilles heel? Can we use a targeted therapy against this tumor? Surgical oncology is going to be with there, obviously decide if they can do surgery, because surgery itself is the only curative option. Everything in the multidisciplinary clinic is to support our patient with chemotherapy, radiation, everything else to try to get them to surgery. Radiation oncology, we can use it for treatment. Sometimes it won't be able to treatment dosages, and we use it for palliation for pain because it's invading the nerves in that area. Dietary is there. I keep telling you it's a systemic inflammatory disease. The primary complaints of most of these patients is going to be pain, weight loss, anorexia, early satiety. This is what they come in and complain about, and they see pretty much every single patient. Palliative care is there to help us with some of the pain and nausea issues as well in an ongoing way. They'll see us during the chemotherapy. They're there at the beginning to help us with that. They're ongoing to help us adjust medications to help them. And nobody gets through this. I say that if you're not a little bit anxious, a little bit worried without seeing behavioral health, we're going to send you to the Psychiatric Institute because there's clearly something wrong. I mean, this is truly, of all things, it's a devastating diagnosis for people and their family, and you have to help treat both. And then there's the genetics of it. And there's an ongoing, we'll talk a little bit about it more, an appreciation that some of these people have germline mutations that make them susceptible. So if we diagnose that with pathology, right, we might be able to tailor treatment to the patient, but it's important to talk to them about their family members who might be at risk for something. Surgical resectability, obviously, it comes in a little bunch of flavors. If they have distant metastasis, if this is spread to the liver, lungs, the peritoneum, which is the covering of the intestines, then they're not going to be cured, but treatment can be palliative in nature. They can have arterial encasement, which we call so-called locally advanced disease. That is, you can't remove it now. Chances are you won't be able to in the future, but we'll try, and we'll talk a little bit about that. And sometimes there's this borderline area where we'll show more information about it, but the idea is it's almost removable, but not quite, and can we help that? And then there's obviously those who are removable. And the big issue about this is that if you take a look at this pancreas, it's sitting right on top of the celiac artery, which goes up to the liver and the stomach, and it's sitting right next to the superior mesenteric artery and vein. And those are not things that you can just willy-nilly cut out because you're going to devascularize a large portion of the gut. So here's a patient who walked in many years ago. We'll talk about her more. There's a large mass right here near the end, near the tail of the pancreas. So the possibilities are to remove this alone, remove it and give her chemotherapy and or radiation afterwards, chemotherapy up front, surgery, radiation, and more chemotherapy. And this patient, when she came in, we were talking about behavioral health and palliative care. Her and her son literally freaked out. Her son was like lying on the ground screaming when he found out that she may have an unresectable, uncurable cancer. And so we actually had to have behavioral health there with us, just to show you that this happens. And though that's an extreme, less extreme cases happen as well. So what about removing this and just giving her chemotherapy, you know, and whatever support? Well, okay, here's our 3 decades of progress. If we look from the 1990s to the 2000s and 80s, you can see these curves have barely changed. If anything, it's gotten a little bit worse, not because the chemotherapy's gotten worse, but because we took on more aggressive cases. But really, we've made no big deal with that. So again, the idea of trying to get everybody together up front to come up with a plan that's individualized. But what about the highlights of this adjuvant chemotherapy? Just quickly, some slides. If you were to remove it, what could we do? Well, you can go back into the late 1990s, early 2000s. There was one looked at 5-FU, 5-fluorouracil, against no chemotherapy, and these numbers pretty much hold out. If you do absolutely nothing at 5 years, survival is about 8% after resection. That means 92% of the people recur and die. If you give 5-FU, about 20% will. It turns out gemcitabine can also give you an approximately 18 to 20% survival. Recently, there was a combination of gem plus oral 5-FU that got this up to about 25%, but we're still a long way from doing really well. And this was a recent study just presented a couple of months ago that looked at giving a bunch of drugs, 5-FU, Irinotecan, Oxaliplatin. This is a hard combination because it causes nausea and anorexia and vomiting, and guess what everybody already has before they start. But you could see that there was an improved median overall survival. And this is not just to tell you about these drugs, but more to tell you, these are all possibilities. How are we going to try to figure out what to do in our clinic? How about neoadjuvant, prior to surgery chemotherapy, which is one of the things we'll be discussing today with our patients. Well, what's the potential benefits? You can get occult micrometastatic disease, which can actually save the patients. What do I mean by that? I see somebody today, we treat them for 2 or 3 months with chemotherapy. Guess what? They progressed and had liver mets. Well, we already talked about it. They had liver mets today. We saved them a potentially morbid procedure. You can decrease the rate of leaving tumor behind, having so-called positive margins. And the other thing is you can deliver the chemotherapy. It turns out, we think we're really cool, we did this ourselves, that if you give chemotherapy, if you do a surgery and remove the tumor, we can get them and finish their chemotherapy, which is 6 months of chemotherapy, because we're really good. Well, it turned out 40% of our patients never made it back to us. They didn't recover from surgery well enough to get that adjuvant chemotherapy. And it turns out you can give it without altering surgery. There's no level 1 evidence, so we mostly do this in trials, that this is better than the opposite way. But we do have some preliminary evidence suggesting it is. So let's go back to that woman that we talked about, large pancreatic tail mass. She ended up getting FOLFIRINOX in 2011. Yes, we were a little ahead of the curve by about 7 years. But we gave it to her. She had a near complete response. Actually, pathologically, she had a complete response. We gave her FOLFIRINOX adjuvantly, and we saw her just a few months ago, and she still has no evidence of disease. Whereas you would have predicted by where this tumor was and the apposition of blood vessels that if we hadn't done something like this, her risk of being dead by now would be 92%. So what's the paradigm we're trying to do in the neoadjuvant area in the multidisciplinary clinic? And that prior to, we're looking at trying to do preclinical studies, pull off clinical trials, and then keep going back and trying to improve upon ourselves or so. So this is the latest trial that we're doing in the neoadjuvant prior to surgery setting. And I could talk about this for 2 hours, but we're not going to. We're going to give you one slide. And the idea is we're giving half the people chemotherapy plus a drug called hydroxychloroquine, which can help alter that stroma to let the chemotherapy in a little bit better. And half the people are now getting an anti-PD-L1. So this is avelumab is like Keytruda and nivolumab, these things that have helped immensely in a number of other cancers and have helped pancreas cancer 0. And we've done earlier trials, and it appears that this might succeed where others have failed, but until we do the trial, we won't know. But by seeing these patients up front, not only can we help them and give them good chemotherapy, we can also try to move the bar in what we know. Okay. So locally advanced disease, we talked about if those people have removable disease. What if they're borderline? What does borderline mean again? You can see here it's just up, it's a budding, it's up to next to these blood vessels. And it turns out that most of these people will recur and die unless you give them chemotherapy and now radiation up front. There's these locally advanced unresectables where now the blood vessel's here inside the tumor. It's completely wrapped around it or so. So how about with borderline disease? What do we know? This is a study from 2012 which really changed things for us, I think. It was 120 patients who had borderline disease. About 2/3 of them eventually underwent removal of their pancreas after neoadjuvant chemotherapy. Median overall survival was far greater than we ever expected in those patients' historical controls. Whereas it was about 8%, it rose to about a median survival of almost 2 years. So what happens in the locally advanced disease setting? This is just to give you an idea. We just went back and looked at data, people who are borderline, people who are locally advanced. And you can follow these things on the PDF, but the important things is if you give neoadjuvant chemotherapy and/or radiation, you get almost all the borderlines through a section, and even some of the locally advanced. about 10 to 20% of these people who we used to say you have no chance of ever having an operation with modern chemotherapy, radiation, and all the supportive measures that go in the MDC, we can actually potentially get you to surgery and possibly cure. So the important thing about this is the multidisciplinary component. There has to be surgical input upon resectability every time you take a look. Is it resectable now? Is it not resectable? Is it growing? Do we have to change chemotherapy? And we're going to have to rely on everybody else in that MDC to help us support that patient to get through their therapy. So a rational balance is some amount of chemotherapy. If there's no evidence of progression, then you can evaluate for resection. We sometimes do radiation prior to that. And if it's unresectable, still switch to alternative chemotherapy until we have no other option but to tell the patient we're going to treat you and support you the best we can, but we're not going to get this out. What about looking at that CA19-9? If it is elevated, can it guide us in that treatment prior to surgery? Turns out if your CA19-9 is elevated and you don't respond, your CA19-9 does not come down as a blood marker, you have zero chance of actually long-term survival. It's not close, it's zero. And you can see the better your response, if it's greater than 90 is better than 50, but anything less than 50, everybody dies. And so we use this as a marker. Granted, we have people who can't be, but if we see the CA19-9 not going down, you're going to have to do something different because we're not helping the patient in that setting. How about metastatic disease? I'm only going to have one slide just to prove to you, just to go through things, not really prove it. Gemcitabine alone, just one chemotherapy drug was shown in the late 90s to improve survival and quality of life. FOLFIRINOX has also been used in the metastatic setting, and it broke this kind of gem backbone. And then shortly thereafter, there's another drug called Abraxane and gemcitabine that got put together, which is helpful. You can sequence these for good performance status patients, and there's some treatments for second and third line as well. And there's a lot of trials that are coming out of chemotherapy plus different immune modulators and other targeted therapies trying to understand in the second and third lines how can we alter the course that is usually once you recur, you die. And to give you an idea, we had a patient who was the very first patient and the only one in the United States, to our knowledge, who got 2 pure immune therapy drugs in one of these Hail Mary trials and actually had a complete response. So now that's only one out of whatever, but it tells you somehow people's tumors are different, and somehow if we can alter those reasons, the stroma, the blood vascularity, maybe we can get these drugs in there and they do have a chance of being helpful. What about the hereditary genetics, as we alluded to? These are all diseases that can increase your risk of pancreatic adenocarcinoma, BRCA. The BRCA genes 1 and 2. 2 primarily is the largest just because it's the most common mutation, especially amongst Ashkenazic Jews. Lynch syndrome, FAP, there's a number of other syndromes, the hereditary pancreatitis, ATM mutations. But what we're doing now is with a lot of these patients is actually going to testing their germ lines as they come through the door, testing their tumors for genomic alterations, because certain drugs can actually help some of these patients, and because even if I can't help you, screening, if not for pancreas cancer, they're still trying to work out how to screen for these high-risk pancreas cancers, and Dr. Randall Brandt, whom you heard from this morning, has got a very active program. But remember, these patients also can get breast and ovarian cancers. So what about targeted therapy? BRCA and a number of these other genes, PALB, which is partner and localizer, have problems in DNA damage repair. And so for instance, normally when DNA gets damaged, there's multiple pathways for fixing this. One of these is the BRCA pathway. One of them is the PARP pathway, excuse me. And what happens is you repair the DNA and the cells go on. So if you actually have a tumor that's missing both copies of BRCA2, and so therefore you can't repair the DNA that way, you're very reliant upon the PARP pathway. And there are now at least 5 PARP inhibitors, and these can all inhibit that. And the idea is that you can cause tumor death. And this has turned out, this is a patient of ours who was found on genomic sequencing to be hereditary BRCA2. He was the index case. His family didn't have it. He had multiple liver metastasis, primary met, and we gave him a chemotherapy plus a PARP inhibitor, and he actually had a complete response. Now, eventually, unfortunately, he progressed many years later, but we were able to keep him alive a lot longer than we normally would have been able to. What about radiation? Well, there's always draw the block box on the patient and just radiate it, and that's proven less than helpful except in a palliative setting for pain. It causes a lot of side effects. It tends not to be able to deliver a lethal dose to the local tumor. But if you have a tumor that's local, right, can you treat it better local? Well, it turns out this thing called stereotactic body radiotherapy. And the idea, this is their planning CT. And what they do is they draw a little bit of box. This is where they want to get the red. The green is everything they want to preserve. The kidneys, the liver, the spleen, your spinal cord, as you can see, right there. And how do you deliver an intensely modulated radiation therapy right to that little area? Well, with a couple of cool machines. And this looks like one of those things that they have an arm, and it actually rotates around the patient, and it's a linear accelerator. And so what it does is it gives a beam this way, it comes from the other side and goes like that. And so what it does is sum up to this little area. Everything receives very little, but this is where all the rays go through. And it's pretty amazing. And we've had a few patients we were not able to remove the tumor from, the longest ones from 2010, who got chemotherapy, got this radiation, and they haven't recurred yet, which is unheard of in locally advanced disease. Not many, but again, edging at the box and trying to understand what we can do. And there's different machines. There's just two pictures of different ones we have. So we're going to end with a case, because that's what we're all like, clinical cases. A 68-year-old gentleman who in 2014 presented with abdominal pain, weight loss, cramping, diarrhea at an outside institution up, I think it was in the Butler area, but I don't remember off the top of my head. He had an EGD and colonoscopy that were unremarkable. They gave him Protonix. They gave him oral antibiotics saying he had bacterial overgrowth, and nothing happened. Now, 4 months later, he's lost about 10% of his body weight. He's having worse postprandial, post-eating pain, which you're going to guess is because he's going to turn out to have pancreas cancers because he's not absorbing things well. He had an outside CT. There was a question of a pancreatic mass. He had an EUS by a local physician. Biopsy was inconclusive. They repeated it, again inconclusive, was referred here. Had an EUS, 3 now, inconclusive. That's not the usual way, but to show you how it can be. And finally, a repeat EUS at the end of May of 2014 suggested adenocarcinoma. The scan appeared to show locally advanced disease, and he showed up in our MDC clinic. And he was complaining of early satiety, weight loss. He lost 5 more pounds as opposed to the 22 he lost before. He had back pain, mid-epigastric pain radiating to his back. It's very common because of the celiac involvement that they have this pain, this band-like underneath their ribs. And he had postprandial nausea, bloating, pain, and diarrhea about 2 hours after eating, very classic for malabsorption. His fasting glucose was up, his hemoglobin A1C was elevated, he was a new diabetic as well, and this guy is not obese. And so radiology and surgeonc, CT scan, looked at it, showed just about 180-degree involvement. Don't worry about the term, but basically they felt it represented locally advanced disease. We saw him, we decided to give him neoadjuvant chemotherapy with FOLFIRINOX, began in July of 2014. Rad-onc saw him, thought he'd be an SBRT candidate before surgery. Palliative care saw him, and on the first day gave him oxycodone for pain, Zofran for nausea, Creon for malabsorption, and referral to behavioral health because, boy, was he anxious. And all those things were really important to keep him on track for the chemotherapy, and still are. Dietary saw him to help him with his diabetes and changing his diet to try to help us, because these patients who continue with poor diabetic control do poorly long term. So this was his original CT scan. We can see this mass that's in this area. By April of 2015, it's far smaller. And you can see a CA19-9. And before we start, the first dose actually rose a little bit, came down very nicely into the normal range. So obviously that's greater than 90% if you're up near 1,000. He had radiation and then surgery, did really well post-operatively. He was too fatigued and too tired to actually get any more chemotherapy after that. Even maintenance, he wanted to be done, which is a very common psychological thing. He relapsed in July of 2016. We restarted him on chemotherapy, this time only including the Irinotecan, not including any Oxaliplatin that can cause neuropathy. And he had a great response. He took a lot of time off, all those little breaks here, between here and there for a year. His CA19-9 started rising, and he had another relapse eventually. We knew it was coming, but he wanted some time to do things and travel, and he came back, and this, if you can't tell, is July 12th, 2018, and he's had a complete response again. And so in order to keep him through all of this, though, there's been a lot of help from the MDC and from supportive care, because we had to treat all of his anorexia, his weight loss, we had to treat the nausea and appetite and neuropathy that's come from his chemotherapy. and referral to try to for his anxiety to behavioral health as well. So these are all those components that I originally showed you. You can see how they all interplay and they try to help us. And with that, I will end with 7 seconds to spare.